and welcome to Wellness Live. My name is Dr. Olivia Moses, and we are so excited that you've joined us today. We want to have a conversation today about a wonderful procedure we do right here at Loma Linda University Health, and that is leg lengthening in our pediatric population. We have a very special guest. We have Dr. Corey Fuller, who is a pediatric orthopedic surgeon here at Loma Linda, who has additional training in leg lengthening. And this might not be a procedure that you have ever heard of or aware of. And we wanted to share with you what we actually do here at Loma Linda in this particular field. And we have a great speaker for you. So without further ado, I'd like to introduce you to Dr. Corey Fuller.
Great. Thanks for having me, Olivia. Okay, sharing my screen. Great. Thank you so much. Hopefully everybody can see that. Let's get right into it. This is my talk here. We're going to talk today about one of my favorite, my favorite topics that I get to take care of, which is leg length discrepancies. Here are the objectives for my talk today: to understand the causes, frequency of leg length discrepancy, how we assess it, the treatment options, and understand a little bit of the history of lengthening, as well as this idea called distraction osteogenesis, which is the basics of it, which you will. So what can cause well, to start off, what is a limb length discrepancy? It's where one leg is longer than the other. And what can cause leg length issues? There are sort of two important concepts to understand. There's what's called a true leg length discrepancy, which is also known as structural, where there's a true shortening of bone or the joint dislocation. So you can see this X-ray up here, and you can see that the right femur bone is longer than the left femur bone. So that's what we would call a true leg length discrepancy, where one of the bones on one side is longer than the other, as opposed to what's called an apparent leg length discrepancy, or functional, which is where the position of the leg is what's creating the discrepancy. So you can see this picture here where this lady is bending her knee. The leg lengths, we would assume the bones are the same length, but because she's bending her knee, now the foot does not touch the ground. So this is important when we take a look at leg and assess leg length discrepancies, because some people have one or the other or a combination of the two. What can cause the true limb length issues? There's both what are called acquired and congenital. Really, acquired, it means you are not born with that difference, but it happened later on in life. And so trauma and a fractured bone that heals short, an infection that causes the bone to be shorter or affects the growth plate. Tumors, other conditions such as Perthes and Blount's that affect the way that the leg grows. Neurologic conditions such as cerebral palsy also can. And then there's congenital leg length differences, such as skeletal dysplasias, congenital limb deficiencies, fibular hemimelia. You can see them listed here, hemihypertrophy. These are all conditions in which patients are born with a leg length discrepancy that often gets worse as they grow. One other important little caveat is that dislocations also will cause a leg length discrepancy. And why that's important is we see kids once in a while. This is something we worry about in very young kids, typically under the age of 1, that are born with their hips dislocated. That also can cause the leg to be shorter on that side. Just a brief overview of the exam. We check the range of motion of the hip, knees, and feet, ankles, to make sure that that's truly a leg length discrepancy and it's not coming from a positional problem. There's an exam called the Galeazzi, where you can see the picture on the left where the right knee is shorter than the left knee. So that clues us in that something is going on. And then we also can use standing blocks to have the patient stand on blocks and feel their pelvis as a way of determining if there's a leg length difference and how much. Next, we often will measure it in exam. In clinic, there are different ways of doing that. The direct way is we usually will use a measuring tape, and you can measure from the pelvis down to the ankle, or from the umbilical cord or the belly button down to the ankle. The different ways of measuring to try to get a measurement of what the difference is. These are truly just screening. They are very susceptible to the position of the patient, and so they're very helpful to determine if there's a leg length discrepancy, but it is not the most accurate. We also will use indirect method called standing blocks. We will have the patient stand on a different block. This is a little bit more accurate because the patient is bearing weight, so it can be a little bit more true of their leg length discrepancy. And we feel their pelvis until it's level, and then we measure the difference on or how much height those blocks provide. But the most accurate way is with X-rays. And there's different methods that we use. This is there's X-rays that normal X-rays will just shoot a beam straight. You can see a picture there. There are issues with the way that those are measured. There's also scanograms where they will measure an X-ray at the hip, knee, and ankle with a ruler. You lay on a ruler and we will measure that out based on where the joints are to the ruler. And more recently, there's new technology such as this machine called an EOS machine that is really becoming the gold standard for measuring leg length discrepancies, where it's a machine that you stand in that takes a front and a side view X-ray at the exact same moment and is calibrated and gives you very accurate information about the leg lengths of the different segments, and why this is typically often better than measuring just clinically is that you can determine where it's coming from. Is it coming from the pelvis? Is it coming from the femur bone, the tibia bone, below the knee, above the knee? And so we can make our measurements as to how much of a difference there is. The effect of leg length differences are really important, and they get bigger as the difference in the leg lengths, one side to the other, goes up. So you can see the picture here. If one side is longer than the other, it doesn't just create a knee height difference where one knee is higher than the other, but it often will cause your pelvis to tilt. You can see in the X-ray there that the left hip is higher than the right hip. That can, especially as it gets more significant, it can cause pain, often in the longer side. So in this particular picture, the left side, you can see that the pelvis is tilted. And you can see that the spine has to accommodate for that so that you can stand upright. So you develop a curve in your lower back, which can also cause back pain and knee pain and ankle pain. All of those can occur in long-standing patients with leg length differences. Again, the larger the difference, the more likely that is to occur. And a lot of people will compensate for it. So you can see here, this is a patient on the left that his long leg is on the left side. And so he has to bend his knee on the left in order to get his pelvis level. And on the picture on the right, that patient, the left leg is shorter, and you can see the patient pushing their foot down to touch the ground. So there's a lot of different accommodations or compensations that patients will do that long-term can have problematic effects on those joints. This was a really good study that was done in our world, the limb lengthening world, looking at the natural history and what do we really know about how common are these? And it's actually really interesting. Having exactly the same leg lengths from your right leg to your left leg is actually quite rare. It's only about 10% of the population is spot on, equal to down to the millimeter. Which infers that 90% of us, this study was done in asymptomatic adults. So these are adults walking around that have never had any problems or known to have a leg length discrepancy. You measure this out on an X-ray, and 90% of patients do have a difference in their leg lengths. And interestingly enough, a small percentage, but real, 5% of people walking around in adults have a difference of a full centimeter and don't even know it. And you can see even though that you can potentially tell when you watch somebody walk even as little as 5 millimeters, most people and authors would agree that below a centimeter of difference is very unlikely to be a problem. It's usually not even noticed. It usually doesn't become a problem until the difference between the legs is more than 2 centimeters. And if you like to think in inches, like a lot of us do, 2.5 inches is 1 centimeter. So that's just a little bit below an inch difference. Fantastic. Okay. Time for questions.
Well, thank you, Dr. Fuller. First of all, just the fact that there is a procedure that can lengthen a leg, I think a lot of our audience is going to be like, wow, this is amazing. So the question is, how did you even become passionate about this topic of leg lengthening, of all the things that you could have a specialty in?
Sure. I fortunate to have trained at Loma Linda myself in my residency, and one of my mentors and one of the pediatric orthopedic surgeons at Loma Linda actually also did subspecialty training in this area, and so I got a lot of exposure during my training and residency, and so I think it was a combination of early exposure to this problem, and also it's a very tangible difference. It's very exciting to see a problem that the patient sees, you can see, and then quite a bit of a process, but months later, you can see this very tangible result, and you can see x-rays that show everything the same length, and the patients do very well. So that is why I sought out subspecialty training, and it's a really, really enjoyable part of my practice.
Yeah, well, it sounds very rewarding. Um, Another question that we actually got from the audience or received from the audience was how effective are orthotics or shoe lifts in restoring equilibrium for individuals with minor leg discrepancies? So, when is surgery appropriate versus let's just do some of these other things that can be purchased?
Yeah, that's a great question. There will be a slide coming up soon that does look into that, just does look at that. In general, sort of the typical management is that under a centimeter of difference, the difference is small enough that most patients won't even notice it. Like I said, 5% of the population walking around has that and doesn't even know they have it. Um, so under a centimeter, we don't unless they're having some specific issues related to it, which is rare, we don't typically treat it. They can walk around with regular shoes, barefoot, no problem. When we get typically between 1 to 2 centimeters, that is when patients usually will start noticing a difference. And there aren't any long-term studies that show long-term problems that if you don't use a shoe lift in that range, but a lot of patients do find that they notice a difference. They feel more even, they walk better. And so a lot of those patients, we typically will give a shoe lift and they try it out. And if they feel better or more equal, then they use it. And most do, and some don't find much of a difference, but the majority do. When you get over 2 centimeters is when it's worth discussing potentially a surgery to permanently equalize the leg length differences.
This is another question is this regularly checked in young children when they are born or when they're developing, or is this something you have to ask for?
No, it is something that is commonly checked. Part of a newborn exam, often the pediatricians will check the hip motion as well as the leg differences. And it is something that is commonly looked at by pediatricians, and it's a very common source of referral from pediatricians to me is to look at patients that are concerned about a leg length difference. So it's usually screened, especially in the first several years of life, by pediatricians.
Okay. So we have another question that came through is what exercises and dietary regimens do you suggest that aid nominal development in children?
Say it one more time, sorry.
So basically, are there any exercises or dietary regimens that can help children in their development when they're, getting taller and, those kinds of things?
There is not any specific regimen with diet or exercises that help them develop to be taller, other than to make sure that they don't have any deficiencies. Specifically, calcium and vitamin D are very important in terms of growing bone. And so to make sure that they don't have any deficiencies in those areas, but typically those are not very common.
Okay. Another question that is coming from our audience is, are there genetic tests that indicate irregular bone development? So they basically, is this something we can identify before birth?
Not typically. There's no genetic test specifically usually for a leg length discrepancy, although there are genetic conditions that often will develop a leg length discrepancy. So it's not something that's usually screened for with genetics, although they do ultrasounds prenatal that they do measure the length of some of the bones. So there are sometimes patients that are picked up on their prenatal ultrasounds. But if there's a particular concern after birth with a genetic problem that usually have other things going on as well, we send those patients to genetics to work up to see if that problem is there.
Okay. Another question that is coming through are Um, when a person has, I'm trying to summarize a number of them, is when people have an issue such as this, can they do this just for, well, maybe you talked about the leg length differences. What if they just want to have it just to be taller? Like I want a kid in the NBA, I'm making things up, but that's kind of a general, can it be cosmetic is the question.
The answer to that is yes. That the cosmetic lengthening for we call it stature lengthening for patients that don't have a difference in their legs, they just want their legs to be longer, is done. It is quite controversial in our field, but there are several centers in the country that do it. It is typically not covered by insurance, so that are often is cash pay. That said, there are patients specifically with dwarfism that do have equal leg lengths but are very short stature. That it is really a functional issue if you are only going to be 3'6" or under 4 feet tall. In that population, it is still has some controversy, but it is much more commonly done in order to get patients to a more normal range for functional purposes in terms of driving a car, using a drinking fountain, whatnot. And so, yes, it is being done in patients without leg length differences.
Okay. So the last question is, how much of a difference can a procedure like this make up?
Good question. We don't we don't really know the limit on terms of bone. We think that bone can keep being lengthened over and over again. What typically limits us in a single surgery is actually the soft tissues, because the muscles, the tendons, the ligaments, the nerve and artery all have to lengthen as well. In general, a single lengthening in the femur, you can typically get somewhere between 5 and 8 centimeters, which is 2 to 3 inches. And in the tibia, below the knee, you can usually do 5 centimeters, which is 2 inches. That said, you can come back, as we do in many patients, and do another lengthening down the road. I've had some patients we've done 3 or 4 separate lengthenings, but you have to space them out to let the muscles and the body accommodate to the new length.
Okay. And just out of curiosity, how painful are these procedures? Because it sounds very intense, this whole process.
The surgery itself is definitely associated with pain that usually resolves in the first week or two. The actual lengthening process is not very painful because it's very slow. We often only lengthen the leg 3/4 to 1 full millimeter per day. So the lengthening itself is not painful, but what is as they get further down the road and their muscles get very tight, they have to go to physical therapy every day or 5 days a week for it. And the therapy can be quite uncomfortable, as the goal is really to maintain your motion while you're doing this. So that's the part that often is uncomfortable.
That makes sense. Well, Dr. Fuller, thank you so much for answering all these questions. And just a reminder to our audience, if you have any questions right now, if you're watching us live, go ahead and type those questions in. And Dr. Fuller, why don't we get to the second half of your presentation?
Fantastic. Okay. I've shared that. Okay. Moving on to our second half. So we touched a little bit into this before regarding the management of leg length. So typically under a centimeter, we observe between 1 and 2 centimeters is often when a shoe lift can be beneficial. And there is no upper limit. And you can, I know an orthopedic surgeon who has a 5 centimeter difference, and he has treated that with a shoe lift, and he is doing quite well. But that is when above 2 centimeters, where doing a permanent surgery to fix the problem, to correct the leg length difference, it makes a lot more sense. And that's usually where the indications on our end start for surgery. So conservative treatment, as we already sort of alluded to, you can wear a shoe lift inside of the shoe, as shown on the left. That is typically 1 to sometimes 2 centimeters can be added to your length with that. At some point, you don't have enough room in your shoe for your foot and the insert. And so you have to start putting it on the bottom of the shoe, as you can see on the right. And although we prefer the insert, because a lot of patients, especially teenagers, they will not wear a shoe with a lift on the bottom to school because it's visible, where the lift on the inside is not something that their peers will see. going now into the surgical management, I like to say when I see patients with leg length difference, the actual principles are pretty simple. If you want to fix the leg length difference, you have to either shorten the long leg or lengthen the short leg. And so there are shortening procedures that we do. Epiphysiodesis is one of those that is very common. That is actually where we shut down a growth plate on the long leg by removing it. You can see a picture of it there. We essentially remove the growth plate. It is a timed procedure. You have to do it at the correct time. You can't just do it anytime you want. And it can't be done after you're done growing. It has to be done during the period of growth. But the idea there is you shut down the growth plate. The long leg is still growing. It's just growing at a slower rate so that the short leg will catch up by the time they're done growing, with the goal of having equal leg lengths at the end. This is a little bit more historic, but we still do it occasionally where we actually just acutely shorten somebody's leg, where we remove a segment of bone and then shorten the bone and fix it back together. It is still done. There are some reasons to do that, but it is not as popular anymore. There are a lot of downsides with it, including some people have a lot of weakness afterwards because the actual muscles, the quad muscles, specifically in the femur, are not shortened too. So your muscles are longer than the bone now, and that can result in some weakness. And that moves us now to lengthening, which has become a lot more common with increases in technology, especially in the last 15 years. So I'm going to introduce you to a concept called distraction osteogenesis. This just means forming new bone as you distract or pull apart the bone. This is something that was figured out about 70 years ago, as we're going to talk about in a minute. And this is the concept behind how we do this, as well as orthopedic surgeons. Oral surgeons use this commonly to reconstruct jaws. You can see a picture of it there as the bone is pulled apart, their new bone forms in the gap. And we're essentially tricking the bone by breaking it. And it's trying, like as if you have broke your bone or fractured your bone. And as it is trying to heal, we're slowly pulling it apart and it will fill in the gap and create new bone. Just a brief history, but it's pretty fascinating. This was really discovered by Elizarov in Russia in the 1940s. He was the one that figured out this concept of really being able to pull bone apart and how it regenerates with new bone. And so he was really the one that described this technique, but it wasn't really. Oh, I was going to point out, and he was a family practice doctor, interestingly enough. But it wasn't known because a lot of this was figured out during the Cold War. And so he really did this without anybody else knowing about it for many years in this small corner of Russia. It wasn't until a very famous in Russia Olympic athlete had a broken bone that was infected and short, that had more than 20 surgeries done in one of the premier institutes in Russia to fix this leg, were all unsuccessful. And he eventually heard about this doctor up in this corner of Russia and had a surgery by him that was successful. So he immediately became quite famous in Russia. But again, because of the Cold War, that knowledge did not leave the country. It stayed within Russia, where he continued to develop it. It wasn't until the late 70s where I think many of you may know this gentleman named Thor Heyerdahl. He was a famous Norwegian explorer and famous for the Kon-Tiki, which was this raft that he sailed across the Pacific Ocean. One of his crewmates actually had an infected, broken, and short bone from one of his previous escapades, and they had unsuccessful surgery done. He was an Italian explorer. He heard about Elizarov, traveled to Russia, and had a successful surgery done. And you can see him here smoking. This was 1980, right after his surgery, which is not recommended. And that's when knowledge really left the country of Russia and entered Italy specifically. Briefly, there were two doctors, Dr. Green and Paley, who traveled to Russia and really were the ones that brought that to America. Dr. Paley is still practicing in the East Coast. And this is a picture of me and one of my partners, Dr. Nelson, when we both did training with him. I did my fellowship with him in 2019, and that is how this knowledge transfer has come about and why we offer this procedure at Loma Linda. Briefly, going now to distraction osteogenesis, the idea behind this is that first step is we do what's called a corticotomy, where we cut the bone, or an osteotomy, where we basically fracture the bone so it's no longer connected. We typically enter this period called the latency period, which is a week after we cut the bone, where we let the bone start to try to heal. You can see in picture one, the first step is the bone will start forming a hematoma, and then you can see number two, it starts to heal. Once we get about a week out from the surgery, we start to pull the bone apart. About 1 millimeter per day is the typical rate, although there are reasons to go faster or slower. And that bone will try to heal back together, but as we keep pulling it apart, it can't heal back together until we get to the length that we want. And then we let it consolidate. This is the period after the lengthening is done, but the bone is not fully healed, while we have to wait till the bone heals before the patients can begin walking again. I thought that it'd be very interesting to show two cases that we have treated at Loma Linda that highlight this. This was a 3-year-old that had a genetic condition called congenital femoral deficiency with a 4-centimeter leg length difference. You can see in the x-rays there, the right femur is about 4 centimeters shorter than the left. And in this particular condition, that gets bigger as the kid grows. So we anticipated that to be closer to 8 centimeters when the child was done growing. So this patient had a lengthening surgery with an external fixator, which has been done for quite some time. It still is a technique that we use to lengthen the bone, but as we'll see in a minute, there are newer ways. So you can see the picture there where the bone is disconnected. There is pins that go above and below, and then there's this frame that they attach to that is on the outside of the leg. And we apply that in the surgery. You can see the leg with the fixator on it there. And then a week after the surgery, the patient turns the little knob on the fixator and it pulls it apart about 1 millimeter per day. And you can see, that just shows how we rotated also in that kid, the femur to get the limb lined up. And you can see here, we follow the patient every 2 weeks typically. And you can see from left to right, those are the x-rays of the leg every 2 weeks. And you can see every 2 weeks, the leg is pulling a little bit further apart. You can see that fluffy, we call it regenerate, that's starting to form in between the two bones. And you get all the way to the right. And you can see now that femur is 8 centimeters longer than when we started. And you can see this beautiful regenerate transversing the area where we cut. That is the end of the lengthening, and then we enter the consolidation period. So if you look at the next x-rays, now these are done a month apart from left to right. So you can see slowly that bone, that 8 centimeter gap fills in with bone all the way until you get to the right, where you can see brand new bone. And that bone is normal bone. I am not 100% sure on this, but I think that bone may be one of the only tissues that regenerates with bone. It doesn't fill in with scar if you do it correctly. Otherwise, if you broke your leg or lengthened your leg and it filled in with scar instead of bone, we'd have a problem. So you can see that on the far right, the bone is fully consolidated. And now in that particular kid, we take the fixator off. During this process, they do quite intense rehabilitation. They work with a physical therapist 5 days a week to make sure that they don't lose motion in the joints above or below. And don't believe that these patients are sitting around doing nothing. If possible, we get them in a pool to do therapy, and they can be very active. Here's one of our kids who's at the beach with her fixator on her leg, and they can be very active during these devices we use are very strong. This was that particular child a year post-op. She was doing quite well, and you can see on that x-ray, we actually over-lengthened the right leg with the idea that the left leg is going to catch up, so that when she is completely done growing, when she's closer to 14, she is going to have exactly the same leg lengths. There is new technology that came out in about 2010 that has revolutionized our ability to do this. We now have rods, just like regular rods that we treat broken bones with, but that have magnets on the inside that are hooked to a lengthening device. And so we can now insert this inside of the bone and that way there's nothing on the outside of their body. It's all on the inside. They use this device that has a magnet on it. They put it on their leg. I think there's a picture here. They put it on their leg. They push the button on the machine. It turns the magnet in the machine that turns the magnet inside of the rod in their femur bone, and that causes the bone to lengthen. And you can see this device has made the process a lot easier for patients to have it on the inside and not have this device on the outside of the leg for several months. And here's a picture of it inside of a tibia. And I will just show you then my last couple slides here is this is the very first lengthening I did with this device in my practice. This was a 14-year-old male. He had a growth plate fracture by his knee, ended up with a 3 centimeter leg length difference. The right side was shorter than the left, as well as he developed what's called knock knee or knee valgus. I will just show you, these are some of the ways we analyze it. You can see we draw a line from the center of the hip to the center of the ankle. We like that to go through the middle of the knee, not out to the side of the knee, which implies he has what we call knock knee. And then this is just the measurements that show that overall this patient has a difference of 3 centimeters, 30 millimeters. The right is shorter than the left. We're looking at those x-rays as if the x-rays are looking at us. So the left side, on our left is the right leg, and on our right is the left leg. So it's like we're looking at the x-rays, they're looking at us. So you can see the right leg is the short leg. This was the surgery that we did. You can put the nail in up from the knee up or from the hip down. You can see that there's a little bit of offset there that was intentional where we cut the bone to get the knee straight. This was 1 month post-op after the surgery. You can see, if you look closely there, you can see down by the knee, there's a gap of approximately 3 centimeters where there's not any bone. And this is then the patient 6 months post-op. And you can see now that the bone in there has healed. The leg is straight on the right. And if you look at the hips and the ankles, they are at the same level. And you can see there's just a close-up of where that rod was, and the bone has completely healed. And this child now, actually teenager, when we did this, has equal leg lengths that will be equal for the rest of his life, as well as a nice straight knee, fixing the problem from that development, how the growth plate injured it. Okay, there is the end of my presentation. Here's just a picture of me. I always have to give credit to my mentors.
Well, Dr. Fuller, thank you so very much. A quick question with that new device, does that stay in the leg?
It does stay in the leg. Typically, we recommend, however, removing it eventually. We leave rods on the inside of bones all the time in our field of orthopedics for broken bones, for fractures. However, this particular device has a magnet and rare earth metals inside of the magnet. And there are some concerns from the manufacturer that leaving that in the long term inside of the body, we just don't know if it could cause issues. So I have had a lot of patients, interestingly enough, that it has remained in there for a while without any issues. But in general, the recommendation is that eventually we come take that rod back out with another surgery.
Okay. We have a couple of questions, and I know we're running out of time, but one of the questions is, at what age is leg lengthening typically considered for children, and are there differences in outcomes based on a child's age?
So that's a good question. You can do a lengthening. There's no age limit. I am currently lengthening a 1.5-year-old leg, a year-old leg. They're typically we'd like to wait until they're older to do the surgery. There are some patients that will have such a large leg length difference that they will need 3 or 4 or even 5 lengthenings. In that situation, like this kid I mentioned, we start early so that we can get all the lengthenings done during their childhood. However, if you do it really young, it often forces you to do it with the device on the outside, the fixator, because those rods that we put in cross the growth plates and they cannot be put in. There's sort of different timelines for them. If the tibia, you can't really do it until they're done growing. In the femur, you can do it as young as 8. Is sort of a number, but in general, if you can wait till they're older, then it typically allows us to do it with the rod on the inside instead of having to put a fixator on the leg, which is much easier for the patient in general to have it all on the inside.
Okay. Another question that we had is, at what age are leg length discrepancies typically diagnosed in children, and how does the condition progress during growth spurts? I think you addressed a little bit of that already.
That's a very good question. I mean, In acquired leg length differences, so meaning like from that kid that we just showed, he
Hmm.
had a normal leg length difference until he had a growth plate injury when he was 13 or 14. Um, and so once that happens, the difference will actually get bigger over time until he's done growing, which in kid boys is usually around 16 in their legs. In the congenital world, so the girl, the other patient that we saw that had that femur lengthening, specifically with the condition called congenital femoral deficiency, that leg actually is, in a lot of times, it's not that much shorter than the other side at birth, but the
Hmm.
leg grows at a slower rate. And so the difference between the legs will get bigger as the child grows until they're done growing. So in those kids, sometimes it's not very noticeable when they're born or when they're young, and it becomes much more noticeable as it gets bigger as they grow. But there's different rates and scenarios depending on the situation, but that one is quite common.
Sure. So the last question that we have time for is, this is a very specific surgery. So if there are parents out there that have children or adults that are looking into this particular procedure, what types of professionals or what qualifications should they be looking in a surgeon to do the surgery for them?
That is a good question. This is a surgery that a lot of pediatric orthopedic surgeons, or in some situations, adult surgeons will do. Um, there is additional fellowship training that you can do, which is not commonly done. And so in general, I do think it's, if possible, to seek out a surgeon that's done additional training just in this area. There is a society that we have called the Limb Lengthening and Reconstruction Society, the LLRS. LLRS.org, I believe, is their website. And you can actually look up on their website surgeons that are part of that organization, which typically would infer that they have an interest in this area and more experience.
Okay, perfect. And if they want to contact us for this particular surgery or to find out more, where can they find out more?
There is a part of our website at Loma Linda that is dedicated to our limb lengthening center that we have at Loma Linda that can be accessed. It's through the Children's Hospital's website. Um, and also we have a email address specifically for patients at Loma Linda that are interested in limb lengthening. It's called limb lengthening at llu.edu that you can email questions to as well.
Perfect. Well, thank you so much, Dr. Fuller, for your time today. This has been such a fascinating discussion, and we appreciate your time and expertise that you donated to us today. And I want to thank our audience as well for joining us for this very, very interesting subject. I want to invite you to November 14. Now, because of the holidays, our next Wellness Live will be scheduled on November 14, and we are going to be talking about global outreach on what we can do. Our world is in a lot of turmoil right now, and what can we do as regular citizens to kind of address that and be of service? So you won't want to miss that particular discussion. My name is Dr. Olivia Moses. Thank you so much for joining us. We'll see you next time.
Thanks.